We move on now to clinical commissioning groups and the authorisation process, and I'm going to ask Barbara to introduce the paper.
Thank you, Chairman. And I think this item follows naturally from the workshop, the development workshop that the board had recently, where we actually, the whole board had gained a better understanding of the authorisation process and how we would deal with that over the coming months. This particular paper looks at some very specific aspects of the authorisation process, and specifically the governance arrangements and the pathway for CCGs from the site visits through to the final confirmation by the board that these organisations would be established and authorised with or without conditions. I think I would like to remind the board authority that we have 212 clinical commissioning groups who have put themselves forward to be established. Those 212 groups cover the whole of England, putting themselves forward in 4 waves. The first part of the process, which is underway for wave 1, is essentially a paper-based exercise, looking at the evidence that the CCGs have submitted. But of course, another important part of that process is the 360-degree review, where we ask stakeholders on the patch for their views of CCGs, and that process is already underway for wave 1 and is an identified process which the board has agreed to for all the waves. I'd also like perhaps just to remind everyone of the 6 domains that we will be assessing the CCGs against through authorisation. We worked with a number of stakeholders and many CCGs themselves some while ago to identify the absolutely key elements for a great clinical commissioning group, and remembering that these organisations will be responsible for commissioning the bulk of health services for their local populations. And if I can just remind you of those 6 domains, 6 criteria. Firstly was that they would be organisations who could have a profound relationship with their patients, their communities and their public. Organisations which were clinically led and had quality and absolutely a relentless focus on quality at the heart of what they do, that they had suitable plans, that they had clear and credible plans as to how they were going to deliver services, that they were well governed so that everyone could have confidence and that they were capable of discharging all their functions, that they had everything in place for necessary collaboration, whether that's collaboration with adjacent or neighbouring CCGs or collaboration with the NHS CBA in its commissioning role, and very importantly collaboration with local authorities and other local stakeholders dominantly through their place on the local health and wellbeing boards. And finally that they had the kind of leadership with the vision and the values that we would want to see to be in charge of such important organisations. So what I'd like to do today is to just ask the board to confirm the arrangements from the point of the site visits. As I say, we've agreed the arrangements up until that point. The first site visits actually take place in September, and the purpose of those site visits will be to identify any gaps that we have seen from the original parts of the exercise, and to see whether those gaps are real or whether the panels are able to reassure themselves on those. It will be an assessment of the leadership. It will be by actually the panel being on site, spending time a whole day with the leaders of those organisations to have an understanding of that leadership capacity and capability. We believe it will be important in the site visits in that we will start to understand the CCG's insight into its own abilities, which we think will be really important, and its preparedness for the future. And finally, I think what's really important is that we've said we wanted this whole process to be developmental and to be a learning process. This will be the first step on the CCG's journey as they aspire to be the very best organisations they can be. And we believe through the process we can not only support the individual CCGs, hopefully they'll come out of this process with a better understanding of their development needs, but also support the board's learning about CCGs and the other factors matters that the board itself might need to put in place in that locality, and also to support the transfer of learning and knowledge across the 212 CCGs by being able to take the examples of great practice that we find in these visits and support other CCGs to understand those examples. The panel will be drawn from a wide range of individuals. The panels who do the site visits will be drawn from a wide range of individuals, and it's important to remember that they will include on them lay assessors, individuals with experience of patient and public engagement, a significant number of clinicians who will be able to focus on quality and safety, as well as individuals from the local authority who will be able to look at that key relationship. It won't be from their own local authority, it will be drawn from a local authority elsewhere, but particularly to look at all those important relationships that they'll have with the health and wellbeing, with the local authority, both through the Health and Wellbeing Board and actually without the Health and Wellbeing Board in some of the joint work that they do. And of course, as well as that, we'll have individuals who are experts in commissioning and have undertaken commissioning roles for years in the past. The members around this table, the board, who will take the final decisions on authorisation and conditions will not be members of those panels, but all the board members have committed to be observers at a number of site visits and to spend the day with a number of CCGs so that we can all increase our understanding to put us in a better position for when we make the final decisions on authorisations at the board. So one of the key areas that I would like the board to approve today is the site visit and the makeup of the panel, and to note that we've all committed to being observers. Once we get all the results from the individual assessments, all these assessments will go to a moderation panel. And the purpose of the moderation panel will be to ensure we have consistency and to ensure that that not only is consistent but it has been robust. We have external support in the site visits, and we'll have external support on the moderation panel to help us with that. But I think it's really important that we ensure that we've got consistency across geographies, so it isn't different in one part of England than another, that we've got consistency across waves, and that we're applying the same basic set of standards whether you're wave 1 or wave 4, and that we've got consistency across panels, because whilst a lot of panels will see many CCGs, and we're trying, particularly with the chairs of panels, and all panel members will go through very specific training to undertake this role, but the chairs of panels will themselves assess quite a considerable number of CCGs, but we need, and that will in itself give us a degree of consistency, but we need to ensure that we've got consistency across the different chairs. So again, now I would be asking the board to agree the moderation, approve the moderation panel. It's then really important that we start to get into the specifics for those organisations, particularly where the assessment hasn't been that they would be fully authorised, as to what the conditions would be and what the rectification plan for those conditions would be. So again, the paper describes the next step in the process, which will be led by Ian and the Operations Directorate, which is the conditions panel, which will look specifically at individual CCGs and determine what those conditions would be. And the paper articulates a range of conditions that are likely to be applied, and I won't go through those. Finally, the final piece in the governance process is I'm asking the board to approve the creation of a subcommittee to look in detail at these applications. We should not underestimate the very tight timetable for authorising 212 CCGs between now and January. And I think that in order to do that, we need a dedicated group of executives and non-executives who will actually have the time to be able to examine the applications and the responses and the results from the moderation and the conditions panel. So if I could happy to answer any questions and take any discussion on that, but those are the 4 areas where I'm really seeking the board's approval.
Thank you, Barbara. Questions and comments?
Yeah, just picking up on the point you just made. So 212 individual authorisations is an awful lot. So is there any kind of funnel or carving up of those to streamline the process so they don't all end up with you doing all 212? And just the second question is really, in this process, does the authorisation then come with it a list of areas for improvement or problems identified in the is that part of the process?
Thank you. Yes, I certainly hope that all 212. So it certainly wouldn't end up with me. And but what we need to make sure is that when they arrive at the subcommittee, we are fairly clear which organisations need the subcommittee to have a detailed look at to make their final decision, and which are fairly straightforward. The CCGs are coming forward in waves. We have 35 in wave 1 already in the process, then 2 rather larger waves in the middle, and again a smaller wave as wave 4. The process is largely going to be delivered by people in our regional and local area teams, and although for the most part they will cover an area outside their normal area, it will be those board staff, and hence the criticality of the previous conversation about those staff and the induction that we have, and ensuring that those staff deliver this process in the way we want it to be delivered, so that it's delivered as in partnership with the CCGs and with a developmental approach. So we will be using very considerable numbers of NHS CBA staff once we've got them appointed in this role. But we've also had to include external resource. Much of the external resource has been helping us do the paper-based sifting, but there will be some external resource on the panels as well.
So is there a high weighting? The 47 senior people that we've already recruited, are a lot of those in the area that's going to be doing the authorisation?
I think some of them, the whole... yes, because there are lots of Marines people. I don't know whether you want to comment, Ian, on the
yes, so there are important roles here for people from regional and area teams, both in the early stages, and indeed right through to if rectification is needed to help organisations discharge conditions and become fully effective commissioners. Those are key people. So the appointments that we've made at regional level and that we've started by announcing today, the area directors and their ability to appoint senior people over the next few weeks to work directly with them, will materially contribute to this work. So it is important that that timetable continues to move forward because of the linkage that Barbara's identified.
And if I can give some further reassurance, the 4 regional directors are identifying the key assessors. I mean, some of the assessors we've got the lay assessors, but they're all in place. We know who those are. They're going through training. The clinical assessors are from other CCGs, and they're all identified. But a great response from local government, who have identified a significant number of individuals to do the assessments. What we've asked the regional area team directors to do is to identify individuals in whom they have confidence to be assessors. So it would mean that individual, they can identify individuals, probably ones who they think are likely to move to jobs in the board, but they are, what they're identifying is people in whom they have confidence because of their knowledge and understanding of commissioning to undertake this role. There will always be a senior board individual on the panels, but actually for the part that's about competence, that what we need to do is somebody who we are confident understands what it takes to run a CCG.
Ed.
Yeah, Barbara, thank you for that. I'm very encouraged by the process. I think the process and the governance and stuff is fine, and I think there are comments about populating the teams and stuff. I guess I'm already moving to the point you made about developmental, and you used 2 words, I think. One was rectification, and the other one was developmental. I'm really keen to understand the extent to which this is truly developmental through a maturity cycle, not just for the CCGs, but actually for us, and the extent to which that is then played back to the public as lessons learned and developmental cycles as we go through into 13-14.
Yeah, thank you. I think perhaps that helps me to answer the second part of your question about the outcomes. I think it has to be both and. So I think that the process needs to be developmental, and particularly for all CCGs, there needs to be a path even the very best, we hope they will seek to have their own development plan, which will make them even better. The other side of the coin, however, it is really important. The board will have a duty to ensure that all these 212 organisations are competent and capable for their very significant responsibility of looking after, ensuring that patients and the public get the right health services and looking after the public purse. So what we, I think that those authorised without conditions, we will see we hope to see a development plan that comes out of this process, which they will want to discharge for themselves. I would sincerely hope that even those that are authorised with conditions will be absolutely in agreement. So the rectification plan, which has to be specific and have time periods and be reassessed as to the CCG's progress against that rectification plan. I think it's really important that in most instances we see that as a joint plan, and that the CCG and the board would agree this is what needs to be done and these are the conditions, and the board and the CCG will see those as necessary and want to put in place the things that remove those conditions. I think we have to be cognizant and be aware that it is possible that for some CCGs insight will be an issue, and I think the board does need to reserve the right, where that is the case, to put in place conditions and a rectification plan, which it sees as important, to ensure that patients get safe services.
I was just linking this to, because again it's a tight timetable to do quite a complex series of tasks, but I was linking it to Tim's role and wondering how public this process is. If a CCGG is given certification without any recommendations, as it were, is that something that the community and individuals will know about, and the transition from what they've got now to CCCGs, how does that work in terms of engaging with patients and communities?
Yes, CCGs have to have a range of documents, some of which are public-facing documents, which will be part of what we look at during authorisation. So it's almost their offer to the public is one of the areas that we'll be looking at. Inevitably, we will publish which have been authorised with and without conditions, and the broad range of conditions. I'll be honest, I hadn't, and perhaps I should have done, given sufficient thought to the publication, to the level of depth of publication as to what those conditions would be. But I'm happy to do some thinking on that with some CCGs and bring that back.
Sorry, just one other thing which I just wanted to struck me. The CCGs, well, it's a question really. To what degree do they reflect the demographies that they will respond to? I'm thinking of places where there is significant minority ethnic populations with specific health and social care needs, and I'm just wondering about how that's reflected in the process.
The CCG governing bodies are diverse and different for every CCG. It is something that CCGs themselves determine broadly who's on their governing body. The chair of the governing body and the accountable officer and the chief finance officer clearly must be on the governing body, but in addition to that they need 2 lay members, one at least of whom must have a full understanding of the community, and also a nurse and a doctor from secondary care. It's interesting that there was initially a great degree of concern that the practices, because in the final analysis CCGs are membership organisations built from the basis of the practices, and our hope is that those practices' intimate relationship with their communities, because lots of them have patient participation groups and very good relationship with their communities, and of course the number of patients that the practices see on a day-to-day basis, that's almost the building block of the policy to make these organisations much more patient and public facing. But there were some concerns initially that the governing bodies would be absolutely dominated by GPs from the practices and would not start to reflect thoughts about their communities and other key stakeholders. It's interesting that we're starting to get some evidence back, actually, that I think the organisations have been really mature and that they aren't absolutely dominated by GPs, that there's a wide range of individuals on the CCG governing bodies, but we will be collecting information on their governing bodies.
Well, thank you, Barbara, very much for the paper. It's an unusual process because it's part regulatory and part developmental. Regulatory bit is a sort of one-off gateway, but you have to put that in the stream of activity that's already been occurring under Barbara's leadership and with her team, and helping to bring on thinking around CCGs and relationships with CCG leaders. And also the use of the gateway process to try to provide constant improvement to make every CCG as good as it possibly can be, and trying to get great outcomes. So it's quite different from a normal regulatory process. And I think that raises the issue of how publicly the imposition of conditions is undertaken and what they are and how that's run. Because actually what we want out of this is not a yes-no binary choice, but everybody comes up a few steps in quality and in purpose and intent. Because at the end of all of this is sheer quality to patients through a clinically led system. And that, I think, brings us to the next phase, which is the ongoing relationship between the board and CCGs, working quite powerfully through your local area teams in development and support and partnership, which is how I conceive our fundamental relationship with the CCGs. It's not a top-down relationship, it's one in which they have the function, they have the resources. We need to establish through this process that we're satisfied that they're capable of being as good as they can be, but we carry on working closely with them from then on. So can I commend the amount of work that Barbara and her team have done to note the close dependency of this process on the last paper and the recruitment that's going to be essential to take it through. And then ask the board to approve the recommendations in paragraph 27 of the report with noted progress. So far as the detailed recommendations are concerned, I think from the discussion around the table that the board are content with the recommendations as to panels, and to also members of our team sitting as observers on the panel, but absolutely not as participants. That's for our education. As much as anything else, and to ensure that when we come as a board to take a collective decision on authorisation, we have imbued ourselves in the process and we understand how it really does work, but we're not taking a view on any of the cases in which we may be present as observers. And then the recommendation for the board subcommittee we will bring back to the September meeting. The recommendation as to the moderation panel I think has to be right, because the regulatory side of this requires that there is some equity and fairness across the way in which we apply our criteria, and you do need that to be independently assessed. And then ultimately the recommendations as to a conditions panel, yes, and we'll think about the public-facing aspect of that. And that, I think, takes care of the recommendations in the paper. Can I just confirm that the board is content with all of those recommendations?
Yeah.
Thank you. We are. Thank you very much, Barbara.